distress syndrome type. Okay, friends, so welcome back. Let us come now to the last part of neonatology, and we'll be talking about respiratory disorders in neonatology. And two respiratory disorders that I would like to talk about are hyaline membrane disease. In short, it is also called as HMD, and transient tachypnea of the newborn, which in short is also called as TTNB. So, what is the full form of HMD? It is hyaline membrane disease. It is also known as respiratory distress syndrome. So, what is the other name? Respiratory distress syndrome. On the other hand, what is the full form of TTNB? It is also known as transient tachypnea of the newborn or respiratory distress syndrome type 2. So, if someone says, what is respiratory distress syndrome? You will say, sir, it's the other name for hyaline membrane disease. If someone says, what is respiratory distress syndrome type 2 or RDS type 2, you'll say, sir, it is the other name for transient tachypnea of the newborn. The first disease we'll do, let us talk one by one these disorders. So I'll first talk about hyaline membrane disease. So just focus on the first column. Just focus on the first column. Hyaline membrane disease primarily is a problem related to surfactant deficiency, and surfactant deficiency primarily in preterm infants. So the thing that you should know is that the surfactant is known to form at around so the surfactant is known to be present in the lungs at around 20 weeks of intrauterine life. So the first time the surfactant can be seen in the lungs of a fetus is at 20 weeks of intrauterine life, and subsequently the surfactant can be seen in the amniotic fluid at 28 weeks of intrauterine life. Finally, the surfactant starts increasing in quantity, and maximum surfactant production is known to occur at around 33 to 34 weeks of intrauterine life. So the first time the surfactant appears in the lungs is 20 weeks of intrauterine life. Then the surfactant appears in the amniotic fluid at 28 weeks of intrauterine life. And then maximum production of surfactant occurs by around 33 to 34 weeks of intrauterine life. So in short, we normally say that any child who is born earlier than 34 weeks of intrauterine life is at a risk of developing hyaline membrane disease. Any child who is born earlier than 34 weeks of intrauterine life is at a risk of developing hyaline membrane disease. It is understandable that more premature is the child, higher is the risk of hyaline membrane disease. A few more things that I would like to tell you. Surfactant is produced by the type 2 pneumocytes. So they are produced by cells which are lining the alveoli, which are the type 2 pneumocytes. Right? Surfactant is made up of phospholipids. So it is made up of phosphatidylcholine. It is made up of phosphatidylglycerol. Then it is made up of sphingomyelin. And then it is made up of surfactant proteins. Surfactant proteins which are subtype A, subtype B, and subtype C. So a surfactant basically is produced by the type 2 pneumocytes which are lining the alveoli, and this surfactant is a type of a phospholipid which is made up of phosphatidylcholine, phosphatidylglycerol, sphingomyelin, and then the surfactant proteins which are subtype A, subtype B, and subtype C. What is the basic function of a surfactant? The basic function of a surfactant is that it lines the alveoli and it reduces the surface tension. So what does it do? It lines the alveoli and it reduces the surface tension in the alveoli. So this is a alveoli, for example, and the alveoli is lined by a fluid. Now what happens is the fluid which lines the alveoli, like any other fluid, has a very high surface tension. So because of the attraction of the molecules towards each other, these alveoli, they tend to collapse. So basic function of a surfactant is it is known to be lined over this fluid and it reduces the surface tension. When it reduces the surface tension, it prevents the alveoli from collapsing. So basically what it is trying to do, it is known to prevent alveoli from collapsing. Particularly during expiration, when we are exhalation. So just try to understand. When we take in air, the alveoli open up. Now when we exhale out air, when we put the air out, what will happen is the surfactant which is lining the alveoli will prevent the alveoli from collapsing in the exhalation phase when we are actually exhaling the air out. So the surfactant will prevent the alveoli from collapsing. And when the alveoli will not collapse, gas exchange will keep on occurring, which will be responsible for the child being able to breathe normally. Do you understand? So a surfactant is made up of phosphatidylcholine, phosphatidylglycerol, sphingomyelin, and surfactant proteins subtype A, B, and C. It is known to be present first in the lungs at 20 weeks of intrauterine life. Then it is present in the amniotic fluid at 28 weeks of intrauterine life. And then it is present in maximum concentration at 34 weeks of intrauterine life. So any child who is born earlier than 34 weeks of intrauterine life will be at a risk of having surfactant deficiency, at least some quantity. And more premature is the child, more is the level of surfactant deficiency, so higher is the risk of hyaline membrane disease. The basic function of the surfactant, it lines the alveoli and it reduces the surface tension, particularly of the fluid which is lining the alveoli. This prevents the alveoli from collapsing during the exhalation phase, and because the gas exchange can therefore occur, the child will be able to breathe normally. Now what happens in the case of a hyaline membrane disease? So what is now happening in a hyaline membrane disease? Actually, hyaline membrane disease is an old name. The new name that is given to this disease is respiratory distress syndrome. So this is a disorder which is associated with surfactant deficiency, mainly because of prematurity. So because of the fact that the child is born premature, so there will be surfactant deficiency. When there will be surfactant deficiency, now you can understand, I've already told you the function of the surfactant. So when the child is inhaling air in, the alveoli will open up. But as soon as the child exhales air out, because now there is no surfactant, a very limited amount of surfactant, the surface tension inside the alveoli will cause the alveoli to collapse. So in the event of surfactant deficiency, the alveoli will collapse during exhalation. So as soon as the child breathes air out, the alveoli will collapse during exhalation. Now when the alveoli will collapse during exhalation, what will happen is that as a result of which the functional residual capacity will decrease. The functional residual capacity, in short we also call it as FRC, will decrease. The amount of air which is left inside the lungs after maximum exhalation that will significantly decrease because all the alveoli now are in a collapsed state. So the functional residual capacity will decrease. When the functional residual capacity will decrease, obviously there will be increased respiratory distress and increased work of breathing. So the child will be starting to breathe very fast. And what will happen? Chest retractions will also be there. So there will be increased respiratory distress and there will be increased work of breathing. Now, when there will be fast breathing and increased respiratory distress, this will lead to hypoxia. What it will cause? It will cause hypoxia after birth. Hypoxia after birth. And if you go back to what I told you when I was talking about a congenital diaphragmatic hernia, just go back and think about congenital diaphragmatic hernia. At that time, I told you, after birth, if the oxygen concentration remains very low, the child is not able to breathe oxygen properly, he is not able to breathe properly. The pulmonary vessels, which in the fetus are in a vasoconstricted state, will remain still in a vasoconstricted state. So this will cause pulmonary vasoconstriction. This will cause pulmonary vasoconstriction because there is hypoxia. So the pulmonary vessels will remain in a vasoconstricted state. As a result of which, there will be increase in pulmonary edema, and hypoxia induced damage to the alveolar epithelium. So there is hypoxia. This hypoxia will cause damage to the collapsed alveolar epithelium. The alveoli are already in a collapsed state. So the alveolar epithelium will be damaged and there will be increased amount of pulmonary edema, which is because of the fluid inside the pulmonary vessels leaking out into the lung interstitium. Because the pulmonary pressures are very high, so the fluid inside the pulmonary vessels will leak into the interstitium. That will cause hypoxia-induced damage to the alveolar epithelium and pulmonary edema. And as a result of which, the proteins such as fibrin will enter into the alveolar epithelium. Sorry, will not enter into the alveolar epithelium, will enter into the alveoli and line the alveoli, resulting in the formation of a hyaline membrane. This is actually the pathophysiology of hyaline membrane disease. Just think of this again. In a hyaline membrane disease, all problem starts from a surfactant deficiency. So when there is surfactant deficiency as a result of prematurity, when the child takes in air inside, the alveoli will open. But when the child breathes out air, during the exhalation phase, the alveoli will tend to collapse because of increased surface tension. This will cause a decrease in the functional residual capacity, the amount of air that remains inside the lungs after maximum exhalation. Now, when the functional residual capacity will decrease, naturally there will be increase in the respiratory distress and increased work of breathing. So the child will start breathing very fast because there is almost no air which is left inside the lungs. So the child will require more and more air. So the child will start breathing very fast. There will be increased work of breathing. As a result, there will be hypoxia. And this hypoxia which occurs after birth will prevent the pulmonary vasoconstriction to turn into pulmonary vasodilatation, which I told you is the normal response when the child after birth breathes high amount of oxygen. No, the pulmonary vasoconstriction which are present in the fetus will remain pulmonary vasoconstriction after birth as well. Now, when the pulmonary vasoconstriction remains, what will happen next? Pulmonary edema will occur, and because of the hypoxia, there will be damage to the alveolar epithelium. So the alveolar epithelium will get damaged, and there will be pulmonary edema. So whatever fluid is present inside the pulmonary vessels will leak into the interstitium. Among this, certain proteins such as fibrin, which are present in the lung interstitium, they will then enter into these alveoli because the alveolar epithelium has already got damaged. So from the lung interstitium, these proteins such as fibrin will enter into the alveolar epithelium and will enter into the alveoli and will start lining the alveoli. And when you see this under the microscope, it appears as a hyaline membrane. That is why the name hyaline membrane disease. So this is again a question for your exams. Hyaline membrane in a hyaline membrane disease. The name hyaline membrane in a hyaline membrane disease is made up of which protein? Answer is fibrin. So what is this hyaline membrane made up of? This hyaline membrane is made up of a protein which is known as fibrin, which lines the alveoli. And this hyaline membrane can be seen when you do a histopathology and see this under the microscope. So the alveoli will be seen to be lined by a hyaline membrane. And this hyaline membrane is made up of which protein? Fibrin. Right, so I hope you have understood the whole process, how hyaline membrane disease or respiratory distress syndrome develops. So what are the signs and symptoms of this condition, HMD? The signs and symptoms will be increased respiratory distress, usually starting within 6 hours of birth, along with a sound which is known as grunting. So grunting is a sound which is heard during exhalation. It is basically a sound which indicates increased work of breathing. So increased respiratory distress starting within 6 hours of birth. Just try to understand, when the child is having breathing difficulty, what will happen is functional residual capacity. I just now told you, functional residual capacity has decreased. Just see this, functional residual capacity has decreased. Now, when the functional residual capacity has decreased, the body will try to maintain the functional residual capacity. So what will happen is, when the child takes in air, alveoli will open. But when the child exhales out air, the glottis will forcibly try to close to maintain the functional residual capacity. When the child takes in air, alveoli will open. When the child exhales out air, now is the time when the functional residual capacity will fall. So as a result, the glottis will try to close to maintain the functional residual capacity. You understand? But the child is hypoxic, so he will try to forcibly breathe out against that closed glottis. That forcibly breathing out against the closed glottis will lead to what is known as grunting. So what is grunting? Grunting is actually breathing out against a closed glottis. And why has the glottis closed? To maintain the functional residual capacity. The chest X-ray signs of this disease are very important. Typical chest X-ray signs are reticulogranular opacity, which is also called as ground glass opacity, along with this air bronchograms. What is an air bronchogram? An air bronchogram is air which is trapped inside the bronchioles. Air which is trapped inside the bronchioles, because below the alveoli are collapsed. So air trapped inside the bronchioles will be seen as very, very thin lines on the chest X-ray. So what is the chest X-ray of a hyaline membrane disease or a respiratory distress syndrome known to show? It is known to show reticulogranular opacity, also called as a ground glass opacity, along with air bronchograms. This is a typical X-ray showing reticulogranular opacity. You can see this X-ray. So you can see this is a grounded glass. There is a normal transparent glass and a glass which has been grounded. When the glass has been grounded, you can see small dots throughout the lungs, throughout the glass. Now this similar picture which can be seen inside the lungs, the X-ray, it is known as reticulogranular opacity or ground glass opacity. So this is a typical example of a ground glass opacity. This is because of the collapsed alveoli. That is why there is ground glass opacity. And this is typical example. You can see these lines. This is the typical example of an air bronchogram. You can see a thin line. This is an example of an air bronchogram. So reticulogranular opacity and air bronchograms is the typical X-ray feature of a condition known as hyaline membrane disease. Reticulogranular opacity and air bronchograms, typical feature of a typical feature of hyaline membrane disease. There are two treatment options for hyaline membrane disease, two treatment options. One is CPAP treatment. CPAP treatment is continuous positive airway pressure. So what is the full form of CPAP? Continuous positive airway pressure. And the second treatment option is directly surfactant administration. So just try to understand what is CPAP therapy. Now in a CPAP therapy, a continuous pressure is given during the exhalation phase of the child. So when the child takes in air, at that time the alveoli they will open. But when the child exhales out air, at this time a machine gives a continuous pressure at the exhalation to keep the alveoli in an open state. So the child takes in air, the alveoli open. As soon as the child takes out air, now is the time when the alveoli can collapse. So at this time, a pressure is given, a distending pressure is given inside the alveoli to keep the alveoli in an open state. This mechanism of administration of positive airway pressure is known as CPAP therapy. What is the full form of CPAP therapy? Continuous positive airway pressure. It is usually given in all children who are more than 32 weeks of gestation. It is given in children who are more than 32 weeks of gestation. And in children who have mild respiratory distress. It is usually not given when the respiratory distress is very severe. It is usually given in children who are not very premature. That means the gestation should be at least more than 32 weeks. A child who is born even before 32, probably not give a CPAP therapy to this child. So CPAP therapy is just helping in the breathing work of the child. The child is taking in air himself. It is only during the exhalation phase that the CPAP therapy is helping. So it is only helping in breathing. It is not doing the total work of breathing. So it can actually help only when 50% of the breathing work or 60% of breathing work is being done by the child himself. That is why it is helpful only when there is a mild respiratory distress. On the other hand, in children who have very severe respiratory distress, or when the child is less than 28 to 30 weeks of gestation, at that time, surfactant administration is more helpful. You know, this condition is because of surfactant deficiency. So it is better to directly administer the surfactant into the lungs so that the surfactant gets evenly distributed in the alveoli, and this prevents the alveoli from collapsing. How is the surfactant administered? Now, in the past, surfactant was primarily administered by a technique which was intubation, then use surfactant administration, and then extubation. So what was it called? It was known as the inshore technique. So IN stands for intubation. So first we used to intubate the child. So in an intubation, what we do is we take an endotracheal tube and put it directly into the respiratory tract of the child. After you have intubated, then you administer surfactant. Then you administered surfactant, and once this has been done and the surfactant appears to have evenly distributed throughout the lungs, then finally extubation. So extubation is the opposite of intubation. Intubation is putting in the tube, extubation is taking out the tube. So this technique was known as the INSHO technique, still is followed at many places, but there is one major problem. And what is the major problem? This always required putting in of endotracheal tube, which was an invasive method. It's not a non-invasive method. Mechanical ventilation and putting in endotracheal tube always led to many problems, including damage to the lungs. Therefore, newer techniques which are being used, which are less invasive and are used for administering surfactant, just know the name of that technique. And one of that techniques should be very familiar to you because your company's name, the main organization's name is related to that technique. What is the name of that technique? So surfactant administration is now more recently being advocated by which technique? By a technique which is known as MIST technique. MIST technique, right? So we are teaching in MIST, you are studying in MIST. So this technique is known as MIST technique. What is MIST technique? Minimally invasive surfactant therapy. So what is this technique called? Minimally invasive surfactant therapy. In short, it is also known as the MIST technique. In MIST technique, we do not put in the endotracheal tube because that is dangerous. That can cause damage to the lungs. What we do in the MIST technique is we administer the surfactant, but basically by less invasive methods. What are the less invasive methods we can think of? The less invasive methods are a very thin pharyngeal tube. A very thin tube is put in the pharynx, and through that tube you put in the surfactant. Another way is nebulization. You can also administer surfactant by giving nebulization. Many of these techniques have not been mastered till now, but at least this is advocated to be a much, much better technique of surfactant administration compared to the older technique, which was the INSHO technique. INSHO technique always required intubation. A surfactant administration technique such as MIST does not require invasive ventilation. So it is a minimally invasive surfactant therapy where we give surfactant, but not by intubating, but probably by giving pharyngeal tubes, by giving nebulization, or even by applying laryngeal masks. So this is what is being advocated now. So which is better? MIST is definitely better in comparison to the INSHO technique. So the current best way of administration of surfactant in a child of hyaline membrane disease is administering surfactant by the MIST technique, minimally invasive surfactant therapy, where we administer surfactant by the pharyngeal tubes, by the nebulization, or by laryngeal mask. The older technique was the INSHO technique, where you used to intubate the child, administer surfactant, and then used to extubate the child. Surfactant administration usually is recommended when the child is less than 28 weeks of gestation or when there is a very severe respiratory distress. In all cases of mild respiratory distress or when the child is more than 32 weeks of gestation, a minimal invasive technique such as a CPAP technique can be helpful. What is the full form of CPAP? Continuous positive airway pressure. So I think this is more than enough for your hyaline membrane disease. Now, just a few words about the second disorder that I would like to tell you, which is associated with respiratory distress. With that, we'll finish up neonatology. The second disorder which is associated with respiratory distress is known as TTNB, transient tachypnea of the newborn. What is it called? It is called as transient tachypnea of the newborn. Unlike HMD, hyaline membrane disease, which is more commonly known to occur in the case of preterms, transient tachypnea of newborn is a problem, respiratory distress, which is more commonly known to occur in terms. Transient tachypnea of newborn is a very, very mild disorder associated with persistence of the fluid inside the lungs. You know, the fetal lung contains a lot of fluid. It is always in a collapsed state. So, the fetus lung is basically in a collapsed state and contains a lot of fluid. Now, when this fluid, which is present inside the fetal lung, it persists even after birth. It should have been removed, particularly because during the time when the child is passing through the vaginal passage, there is pressing of the vaginal walls over the chest, due to which the fluid comes out. This is one of the mechanisms. There are many other new mechanisms which have been advocated. But please remember, any child in whom this fluid continues to remain inside the lungs. Fetal lung always contains fluid. But the moment the child comes out, this fetal lung fluid comes out. So now, once the child is born, if this lung continues to contain a lot of fluid, the air will not be able to enter into the lungs. So what is known to happen is, if this fluid remains inside the lungs, even after birth, then this is known to result in less air entering into the lungs after birth, a condition which results in transient tachypnea of the newborn. Now, because one of the mechanisms by which the fluid is known to come out of the lungs is the vaginal walls pressing against the chest cavity. So when there is a normal delivery and the child passes through the vaginal passage, the vaginal walls press the chest cavity and the fluid is squeezed out of the lungs. Now, when this fluid is not squeezed out of the lung, say for example, the child being born by a cesarean section. So in a cesarean section, the child is not born through a normal vaginal delivery. So that fluid is not squeezed out. So it will result in persistence of fluid remaining inside the lungs, a condition that results in transient tachypnea of the newborn. It is only a transient tachypnea which improves on its own in 48 to 72 hours time. You do not need to do anything. It will improve on its own. Only some supportive management is given, and by about second to third day, most of these children improve on their own. Please remember, there are some new mechanisms also which have been advocated by which this fluid comes out of the lungs. But for your examination purposes, please remember, if this fluid remains inside the lungs, it will result in a transient tachypnea in a newborn after birth. The chest X-ray findings include fluid in the interlobar fissures. So that fluid which is present inside the lungs, it actually is known to lie on both sides of the interlobar fissures. You can see here, you can see the arrows. So this is the interlobar fissures, which can be very prominently seen. Interlobar fissures, which can be very prominently seen. And these fluid in the interlobar fissures or prominent interlobar fissures, with or without pleural effusion, is the classical X-ray finding in this condition. This is also sometimes referred to as the star burst appearance. So this X-ray picture is also sometimes referred to as the star burst appearance. What is its other name? It is also called as the star burst appearance. What was the X-ray picture in a child of hyaline membrane disease? The X-ray picture in a child of hyaline membrane disease was reticulogranular opacity or ground glass opacity and air bronchograms. What is the X-ray picture in a transient tachypnea of the newborn? Fluid in the interlobar fissures, making these interlobar fissures very prominent. Pleural effusion may or may not be present, but the interlobar fissures are very prominent, as I just now showed you in the X-ray. This picture is known as the star burst appearance. The treatment is symptomatic. As I told you, no actual treatment is required. The treatment is usually supportive, and most of these children improve on their own in 48 to 72 hours time. Unlike in hyaline membrane disease, where the treatment will include, as I told you, based upon mild respiratory distress or severe respiratory distress, so it may include CPAP therapy, or it may include surfactant administration by in-show technique or mist technique. In the case of TTNB, you do not require any specific management. Most of the cases, the treatment is symptomatic. So with this, we finish up neonatology. And let me tell you, this is apart from cesarean section, I told you this is also known to commonly occur in infant of diabetic mothers. I told you, infant of diabetic mothers, when I was telling you the complications, I told you the complications of infant of diabetic mothers. I told you low cost MRP. MRP, R stands for respiratory distress. And I told you both hyaline membrane disease and transient tachypnea of the newborn are seen in infant of diabetic mothers. So infant of diabetic mothers can have hyaline membrane disease also and can have transient tachypnea of the newborn also. So TTNB not only is known to occur in children who are born by cesarean sections, TTNB is also known to occur in children who are born to diabetic mothers. So TTNB, elective cesarean sections, children born by elective cesarean sections, and also children who are born to diabetic mothers. With this, we finish up neonatology, the second chapter. I hope the second chapter was informative to you. I always feel neonatology for PG entrance exams also, and as well as for your missed exams, this FMG exam, this is very, very important topic. And that is why I always focus a little more on neonatology than any other chapter, because this is something which is very, very important. Neonatology is a little hard, but ultimately this neonatology, if you have understood the concepts, if you have understood, so neonatology may appear to be a little hard, but once you have understood the concepts, these concepts will then become very clear and you will remember these concepts lifelong. So growth and development done, short stature, milestones, growth assessment markers, breast milk. Neonatology done, general aspects of neonatology. Then we talked about neonatology specific problems, hyaline membrane disease, respiratory distress syndrome, type 2, which is TTNB. Then we talked about neonatal jaundice. We talked about perinatal asphyxia, necrotizing enterocolitis. We talked about HIE, and we talked about terms, preterms, how to differentiate them. We talked about caput secundum, Keffel hematoma. We also talked about umbilical cord. We talked about complications in infant of diabetic mothers, diaphragmatic hernias. So I think you have understood these two chapters thoroughly. Now we start with the third chapter, which is pediatric cardiology, in which my main focus will be congenital heart diseases. Let me tell you, after having gone through FMG questions, the type of congenital heart diseases that are asked in PG entrance exams are way 3 or 4 steps higher in comparison to what is asked in FMG exams. So for FMG exams, you have to be very, very familiar with just general cardiology, general congenital heart diseases, which type of congenital heart disease fits into which category, what are the X-ray appearances in different congenital heart diseases, and which syndrome is commonly associated with which important congenital heart disease. So that will be the basic focus of my third chapter, which is congenital heart diseases. So I start my topic of congenital heart diseases and cardiology with a small talk about the fetal circulation. So first I will talk about the fetal circulation, a few things that you need to know, and then we'll talk about congenital heart diseases. So right now we are talking about fetal circulation, which is the circulation before the child is born. So before the birth of the child, the circulation, we'll talk about it, and then we'll talk about congenital heart diseases. Now, let me start by telling you that in the fetal circulation also, the heart normally has four chambers only. That is the right atria, then you have the left atria, then you have the right ventricle, and then you have the left ventricle. In the fetus, from the lower half of the body, the blood comes into the inferior vena cava. So this is the inferior vena cava. So blood is entering into the inferior vena cava and is going to the right half of the right side of the heart. The main organ which is performing oxygenation function is the placenta in the fetus, and the oxygenated blood from the placenta is known to enter through the umbilical vein, and this blood which is oxygenated, so if it is oxygenated, let me show it in red. This blood which is oxygenated is known to enter into the inferior vena cava. So 50% of the blood bypasses the portal circulation and enters into the inferior vena cava through what is known as the ductus venosus. Right? So blood from the umbilical vein coming from the placenta. So this is oxygenated blood. Umbilical vein is the only second vein in the body which, although is a vein, is known to carry oxygenated blood. The other vein is the pulmonary vein. So all other veins carry deoxygenated blood. Umbilical vein and the pulmonary veins are the only two veins which carry oxygenated blood. So all the blood which is oxygenated in the umbilical vein, 50% of it bypasses the portal circulation and enters into the inferior vena cava through the ductus venosus. So ductus venosus is a link between the umbilical vein and the inferior vena cava. So the inferior vena cava therefore becomes oxygenated, and this blood then enters into the right side of the heart. So because it is oxygenated, I am drawing it in red color. Now once the blood enters into the right atria, this blood now gets divided into two. About 1/3 of this blood will enter into the left atria, about 1/3, while about 2/3 of this blood will enter into the right ventricle. So 1/3 of this blood has entered into the left atria, while 2/3 of this blood has entered into the right ventricle. Let us forget right ventricle for the time being. The blood that has entered into the left atria, now this is the right atrial blood. The blood that has entered into the left atria will now enter into the left ventricle. From the left ventricle, this blood will enter into the aorta. Now from the aorta, this blood will go up into the ascending aorta, into the arch of aorta, and then into the descending aorta. All of it is purely oxygenated blood, or mostly oxygenated blood. That is why I am showing it in red. The upper half of the body, that is the brachiocephalic, the carotid, and the subclavian. So these are the three arteries which are rising from the arch of aorta. Brachiocephalic, carotid, and the subclavian. All of it is getting oxygenated blood. So the upper half of the body, including the brain, is getting oxygenated blood. This is very important. The upper half of the body, including the brain, is getting oxygenated blood in the fetus. Even the coronary circulation is the circulation which supplies the heart. Even the coronary circulation starts from the ascending aorta and therefore is also getting oxygenated blood. So the most important thing, brain as well as the heart, both require oxygenated blood, and both are given oxygenated blood in the fetal circulation. I hope till here you have understood. I'll again repeat. Blood from the lower half of the body enters into the inferior vena cava, like in a body also. Inferior vena cava. Now from the inferior vena cava, it is going up into the right side of the heart. Now when it is going into the right side of the heart, the placenta, which is forming the main in the fetus, sends its oxygenated blood into the umbilical vein. This oxygenated blood, umbilical vein blood, it bypasses the portal circulation. 50% of the portal circulation is bypassed, and this umbilical vein drains into the inferior vena cava through what is known as the ductus venosus. So it is opening into the ductus venosus, which then opens into the inferior vena cava. So what is ductus venosus? In a way, it is a link between the umbilical vein and the inferior vena cava. From here, the blood enters into the right side of the heart, that is the right atria. Now, normally in our body, all the blood that enters into the right atria will go down into the right ventricle only. But not in the case of fetus. In the case of fetus, there is parallel circulation, not series, parallel circulation. That means once the blood has entered into the right atria, 1/3 of it will enter into the left atria, while 2/3 will enter down into the right ventricle. So it is getting divided. About 1/3 will enter into the left atria, while 2/3 will go down into the right ventricle. Let us forget right ventricle for the time being. Once the blood has entered into the left atria, this blood enters into the left ventricle. From the left ventricle, this blood will enter into the aorta, because the aorta arises from the left ventricle. So this blood will enter into the aorta, then it will enter into the ascending aorta. It will go up, and the coronary circulation is the circulation which supplies the heart. It arises from the ascending aorta. So because ascending aorta is oxygenated blood, most of the heart gets oxygenated blood, even in the case of fetus. Then this blood in the aorta goes up into the arch of aorta, and arch of aorta, there are three arteries which are rising. One is known as the brachiocephalic, one is known as the carotid, one is known as the subclavian. So basically the brain, where this carotid arteries go, basically the brain is also getting oxygenated blood in the case of a fetus. The remaining blood, as you can see, enters down into the lower half of the body, and then again mixes with the deoxygenated blood, which I will tell you how that deoxygenated blood will enter here. This is about the lower half of the body. Let us now talk about the upper half of the body. Now let us talk about the upper half. Now lower half of the body, blood is entering into the inferior vena cava. Upper half of the body, as happens in our body also, blood enters into the superior vena cava. So this is the superior vena cava, and this blood will enter into the right atria. In our body also it enters into the right atria. Here also it will enter into the right atria. Now this blood, because it is deoxygenated, I will mark it as blue. Now there is no umbilical vein which is opening, unlike here where the umbilical vein is opening into the inferior vena cava. So inferior vena cava becomes red, oxygenated. But in the case of superior vena cava, there is no umbilical vein opening here. So superior vena cava blood remains deoxygenated. So which has a higher concentration of oxygen? Superior vena cava or inferior vena cava? Obviously it is inferior vena cava. This deoxygenated blood from the right atria then will enter into the right ventricle. It does not go into the left atria. So the left atria remains oxygenated. This blood from the right ventricle will enter into the pulmonary artery. So the pulmonary artery, it arises from the left ventricle, pulmonary artery. And from the pulmonary artery, this blood starts going up into the lungs. So it should normally go to the lungs. But will it be able to go into the lungs? Answer is no. What is the reason why it will not be able to go into the lungs? Because I again go back to the same thing that I told during diaphragmatic hernia. Lungs, pulmonary pressures are very, very high in the fetus. So because the pulmonary pressures are very high in the fetus, lungs will not allow blood to enter into the lungs. So only 10%. Oh, how much blood? Only 10% blood is able to enter into the lungs. Only 10% blood is able to enter into the lungs of a fetus. Remaining 90% of blood, what happens to it? Remaining 90% of the blood, please see here. So blood cannot go into the lungs. No. It cannot. So remaining 90% of the blood will shunt through the ductus arteriosus. This is the ductus arteriosus. Will shunt through the ductus arteriosus and will enter into the descending aorta. So this is the ductus arteriosus. Please don't confuse ductus arteriosus and ductus venosus. What is ductus venosus doing? Ductus venosus, you can see in red here. Ductus venosus, what does it do? Ductus venosus is the connection between the umbilical vein and the inferior vena cava. But what is the ductus arteriosus? It's the connection between the pulmonary artery. Just see here where I marked the star. It is a connection between the pulmonary artery and the aorta, the other star. So it is basically connecting the pulmonary artery to the aorta because the blood cannot go up into the lungs. So most of it gets shunt. So what happens is in the lower half of the body, let me make it blue again, there is mixing of oxygenated and deoxygenated blood. Some oxygenated blood will be there, some deoxygenated blood. Most of this will enter then into the umbilical artery and go to the placenta again for oxygenation. After oxygenation, again it will enter into the umbilical vein and the same process will continue. This is fetal circulation that you should know for your exams. Now, I'll repeat again. Blood from the lower half of the body enters into the inferior vena cava. Now, inferior vena cava, this blood is going up into the right atria. Placenta, the pure blood, which is oxygenated blood, enters into the umbilical vein. Please see this umbilical vein, and umbilical vein connects to the inferior vena cava through the ductus venosus. This oxygenated blood, which is in red, enters into the right atria. So this is the right atria. RA is the right atria. From the right atria, see there are two red arrows. One is going into the left atria. So about 1/3 blood will enter into the left atria and about 2/3 blood will go into the right ventricle. So the left atria now, as you can see, let us focus on the left atria. The left atria, LA, continues to receive only oxygenated blood. This left atria oxygenated blood then enters into the left ventricle, and from the left ventricle it enters into the aorta. So you can see the aorta is receiving oxygenated blood. This blood from the aorta then goes up into the ascending aorta, and the coronary circulation, the circulation to the heart, is arising from the ascending aorta. So the heart is receiving oxygenated blood. Then this ascending aorta blood goes up into the arch of aorta, and the arteries which supply the brain, including the carotid, which are arising from the arch of aorta. So the brain will receive oxygenated blood. Then this arch of aorta then turns down into the descending aorta, and this blood enters into the descending aorta. Regarding the upper half of the body, the blood from the upper half of the body enters into the superior vena cava. From the lower half of the body, blood was entering into the inferior vena cava. But from the upper half of the body, the blood is entering into the superior vena cava, which again enters into the right atria, RA. All this blood from the superior vena cava will go only down into the right ventricle. You can see the blue arrow going into the right ventricle, RV. So while the red arrow is dividing into left atria and right ventricle, the blue arrow is going only into the right ventricle. This blue arrow then enters into the pulmonary artery. So the blood now enters into the pulmonary artery from the right ventricle. This goes up, and pulmonary artery normally should go into the lungs. But will it be able to go into the lungs? No, I told you there is very high pulmonary pressure. State of pulmonary hypertension is normal in a fetus. So it will allow only 10% of blood to enter into the lungs. Where will the remaining 90% blood flow? It will pass through the ductus arteriosus. It will shunt into the descending aorta. And because this descending aorta, see the star, this descending aorta is just distal to the left subclavian. So this is the left subclavian artery. So because the descending aorta is distal to the left subclavian artery, you actually have mixing which happens only in the lower half of the aorta. You do not have mixing which will occur in the part which is going to the brain and in the part which is going to the coronary circulation. So this blood which is entering into the lower half of the body enters into the descending aorta, then through the umbilical artery again enters into the placenta, and the whole process starts all over again. I hope now this is pretty simple and you have understood the fetal circulation very well. I have tried to make you understand the fetal circulation as easy as possible. If you remember this, I think you will be able to answer maximum number of questions in the exams on fetal circulation. Now, what is happening after birth? Now, after birth, there are few changes which starts to happen. The first change that starts to happen after birth, the first change that starts to happen is that the lungs expand. And when the lungs expand, what will happen is the pulmonary arterial pressure will fall. Pulmonary vasodilatation occurs, so pulmonary pressure falls. So, and second thing what happens is the placenta is removed. The placenta is a low pressure circulation. So as soon as the placenta is removed, what will happen? The pressure in the aorta will start to now increase. So the pressure in the aorta will start to increase. So the pressure on the left half of the body will start to increase, while because the lungs are expanding, the pressure on the right side, that is the pulmonary artery side will start to decrease. So what is happening now is pressure on this half of the body is decreasing and pressure on this half of the body is increasing. It was opposite in the fetus. In the fetus, pressure on the right side, this is the right side. Pressure on the right side was more and pressure on the left side was less. But now after birth, pressure on the right side has started to decrease and pressure on the left side has started to increase. As a result of which, what happens is lungs expand, so the pulmonary pressure will start to fall. So now once the pulmonary pressure will start to fall, please now understand this. So here was the placenta, right? This was the blood which was coming from the placenta and was entering into the right atria, right? And from the right ventricle, this was the blood that was going up into the lungs, but was not able to go into the lungs. Now what has happened is that the pulmonary pressure has started to fall. As the pulmonary pressure has started to fall, now the right ventricle starts to go into the lungs because the pulmonary pressure has now fallen. So now the right ventricle does not passes through the ductus arteriosus. This was the ductus arteriosus, this was the ductus arteriosus. So initially what was happening is the blood was passing through the ductus arteriosus. Now what happens is this suddenly stops. So although the ductus arteriosus may take some time to disappear, but now most of the blood will start going up into the lungs. It is not passing through the ductus arteriosus. Why? Because the pressure now on the aortic side of the ductus arteriosus increases and the pressure on the pulmonary side of the ductus arteriosus decreases. So now the blood cannot enter into the right side to the left side more. So this blood which is now from the right ventricle starts to go up into the lungs. More so now what has happened, the placenta has got removed. So this removes. So now whatever blood was coming from the lower half of the body and was entering into the inferior vena cava is now going directly